an original MCM production.
Now, to get to our program, Dave Murphy, Vice President of Marketing and Communication at Marquette University, will introduce our speaker. Dave?
Thank you, President Dan, and good afternoon, all. Today's speaker, Dr. Nick Turkal, is President and CEO of Aurora Health Care. Now, the first time I met Nick was about 10 years ago, and I was immediately struck by how genuine he was. He was thoughtful, he was caring, the kind of guy that you could work with, not necessarily just for. He didn't fit my image of the hard-driving CEO of a major healthcare concern. I guess his leadership style was much more akin and rooted as a doctor. Come to think of it, I was thinking, he'd be a great family physician. I wish I had him as my doctor. And then I later found out that Dr. Turkal still sees a small number of patients in addition to his day job. So I'm lucky enough to work with a similar person, not a doctor, but an engineer, Marquette University President Mike Lovell. Nick and Mike, they have a lot in common. Both are what I call quiet leaders. Both are collaborators. Both are avid runners. And then there's the Jesuit connection. Nick attended Creighton University, another Jesuit education institution. Excuse me. And he went to Creighton for his undergraduate and medical degree. And both are visionary, working closely together to help bring some exciting projects and partnerships. Today you'll hear, thank you, Mary. Today you'll hear more about the partnership between our two organizations, the great things happening here in the city, like Marquette University and Aurora partnering on a new state-of-the-art athletic performance research center, and the Near West Side Partnership, which is bringing redevelopment in and around our campus. It's leaders like Nick and Mike and others here in the room that are looking at the big picture and what will bring the greatest change for our community. And not one entity alone, it's together. And genuine people do that. Please join me in welcoming Dr. Nick Turkal.
Thank you. Pleasure to be here. That was one of the nicest introductions. Thank you, Dave. I really appreciate it. So I thought I'd talk today about the power of partnerships and how private institutions can really make a difference for our communities. That's not a big stretch for all of you to think about. This organization is very involved in partnerships. What you do with MPS, what you do with Honor Flight, what you do in so many areas is about partnership. So you know where I'm coming from to begin with. But I want to get into the weeds a little bit today on a few things that we're doing and tell you why we're doing them, what I think the result might be for our community, short-term and long-term. I don't use a lot of quotes in my talks, but I had two today that I found would be particularly helpful as context if you could think about these as I talk about our projects. First one's from Henry Ford. And I'm sorry to my father, who worked for General Motors for 40-some years, that I'm quoting Henry Ford. But Henry Ford said, coming together is a beginning, keeping together is progress, working together is success. So keep that in mind. The other one is an African proverb that I really like. If you want to go fast, go alone. If you want to go far, go together. That's really profound if you believe in partnerships and all the complications that go with them. And I'll talk now a little bit about the backdrop of partnerships with just a couple of minutes on healthcare. I was here about 2 years ago and talked about the rapidly changing environment in healthcare. It's only gotten quicker. The speed of change has picked up dramatically in the last couple of years. And I think I shared with you last time that we're an industry that needed some reforming, so I welcome the changes that are happening. But if you think about a rapidly changing environment that was so stable for 50 years, the way we got paid, the environment we worked in, very stable for 50 years, then you begin to think about changing business models, how we're paid, what happens in the communities. The pressure is on us to choose wisely how we invest resources and how we change healthcare for the better. A couple of things are going on nationally, and I'm going to use an example. Interesting, I didn't know that Dr. Kassam and his wife Greta were going to be here today because I'm going to use him as an example. Innovation in healthcare is something that's incredibly important. We have to make progress on the things that make a difference to people. So right down the street at St. Luke's, Dr. Kassam leads a team that is using a brain mapping technique that allows him and his team to take out tumors at the microcellular level in a way that's not being done anywhere else. So people from around the world are coming to see what we're doing here in Milwaukee. That sort of innovation comes in an industry that is disrupted, and we got a lot more to do together on that front. So thank you for being here. Along with innovation, the other trend that we're seeing nationally is consolidation. And you probably read about this in healthcare. Organizations coming together, getting bigger, feeling they have to get bigger to be successful. So a couple of words about that. First of all, we don't know how big is the right size in healthcare. So what people are doing now are testing out to see what they can do to make it all work. But we have, on the one hand, the government with Obamacare and the way we're reimbursed by Medicare, for example, that is pushing organizations to be larger and take care of populations. On the other hand, we have the Federal Trade Commission who's saying, we don't like hospitals coming together. There needs to be more competition. So it's an odd environment out there. Consolidation will continue to happen. We see it in our market. We've seen it nationally. If you look here locally, Ascension Healthcare acquired Ministry and Wheaton, and previously Columbia St. Mary's. So we feel that here in our market. We've taken a little different approach at Aurora and feel that the traditional merger and acquisition approach maybe isn't what we want to do, at least not what we want to lean into right now. So while we're open to all kinds of transactions, we focus more on partnerships. And when we do things at a time when we have to invest carefully, our team does a nice job of saying, what's the filter? Why do we want to work on partnerships now when that was not the mode that Aurora was in a dozen years ago? A couple of things. First of all, partners, if you partner correctly, I believe can bring the best of a couple of organizations together, and you can leverage the strengths. Sometimes with traditional M&A, if companies feel jammed together, you lose some of those unique, wonderful qualities. So we're trying to find a way to get the best of both organizations. I mentioned the regulatory environment. I think that scrutiny on merger and acquisition in healthcare will continue, and it's not sorted out yet. There's an interesting battle going on in Chicago right now. And finally, we have to be really diligent about cost reduction in healthcare. So the partnerships that we look at, we're trying to find ways to get more efficient or learn things that will make us better at what we do. So those are a few of the filters we use. I'm going to give you two examples before I talk about Marquette of partnerships that may seem a little atypical, or if you're looking from the outside, you might say, why do you do that? The first one we announced a couple of months ago. It's a joint venture with Anthem Blue Cross Blue Shield. We've created a new insurance company in Wisconsin called Well Priority. Anthem is really good at insurance, and we're really good at providing health care. I don't want Aurora to be a full-time insurance company, and Anthem doesn't want to be a provider organization. But for years, there have been these barriers between healthcare and insurance that haven't taken the best of both worlds and used it to the benefit of the people we serve. So as we come together with our Well Priority product, the idea is we're going to go to market with a focus on wellness, go to companies and say, how can we work with your individual population, and how can we get costs down? That's a different approach than we've taken with insurance companies in the past. And if we do that right, it's going to be a significant change in the market. So that's one example. We have by the way, we didn't start that without a track record. We worked with Anthem for about, I think we're in our 4th year now of working with individual companies, designing plans for those companies to get their costs down. We have to do that. You all know what healthcare costs have done to businesses around this country. We have to get the cost down. The other example I'll give is another Wisconsin example. It's an organization we put together and announced about 18 months ago called About Health. We have 8 organizations across the state of Wisconsin that have come together, 8 healthcare organizations. We selected them based on people who are providing higher than average quality in their care and lower than average cost. So the members of that include Aspirus, ThedaCare, Bellin, Pro Healthcare, UW, Gunderson, and Marshfield. Names you'd recognize in healthcare from around the state. Whoever thought we'd be working with Pro Healthcare, right? You know, just a moment of silence for that, because when I started, that was a big battle. That organization came together for really one purpose. We felt with the changing environment in healthcare, we had to be able to offer access across the state of Wisconsin. Important for the exchange products, important in the future for state employees, important right now for companies that are not just in the Aurora geography but span the whole state, and important for national companies that have employees here and want to buy a state-based product. So we came together to get clinically integrated, meaning we all do things pretty much the same way clinically, and we contract together, and we're doing that. The interesting thing about this partnership is what we've learned in 2 years about each other, what we're taking and spreading across the state to get costs down and increase quality. So you might think if you put 8 healthcare CEOs in a room together, some of us who have been fiercely competitive and still compete with each other, that it might be a disaster. But every one of those people has been able to check their ego at the door and figure out a way to bring the best of their organization. So Gunderson, for example, has a community-wide effort on end-of-life care and advanced directives. Nationally known for that. We're taking that and spreading that across the state. Taking the strengths of each organization and working together for the long haul. It's not easy, by the way. You know, some people would say it's easier to go out and acquire and do M&A activity, but I think it's more sustainable and better for the patients we take care of. So that's a couple of examples, and we have other partnerships that we do across Wisconsin and Northern Illinois, but that's a couple of background ideas that are healthcare related. Now I'd like to talk about Marquette and the Athletic Performance Research Center. This is an exciting, fun, and game-changing project for not just the organizations, but our communities. Since we announced this a few months ago, it's been very interesting to see the reaction. A lot of positive reaction to me about investing in the community, about working with Marquette. So that's been great. But also some people kind of scratching their heads and saying, I'm not sure I get what you're doing or why you're doing it. So let me give you a little bit of background. First of all, Aurora and Marquette have worked together for decades. We've provided care to students and faculty. We're neighbors. We've worked together on academic programs. So we had a basis, we had a relationship to work on that was very helpful. Then a couple of years ago, we both became anchor partners in the Near West Side Partners Project, which is anchored by not only Aurora and Marquette, but Harley, Potawatomi, and Miller. We've committed to really enhancing and improving that Near West Side. We have great results in less than 2 years around what we're doing to bring businesses in, get some things out, like the tobacco store that wasn't really a tobacco store. We've had some legislative changes. It's been very positive. So we had that as a basis. And then enter Mike Lovell, who dropped by my office with a little poster back in October and said, I got a crazy idea. And I'll say a couple things about Mike. You said some nice things about him. He is intensely creative, and he's extraordinarily persuasive. So, so if Mike comes and knocks on your door, beware. I really love working with him. He's great. But from concept back in October to approval by our boards was only a couple of months. That included a $40 million investment by Aurora. We don't take that lightly. And Marquette and their board don't take this lightly. So why are we doing this? We're taking 12 acres between 6th and 10th Street and between Michigan and the interstate, an area that most of you know if you've driven by has not been a great part of Milwaukee. It's kind of at the edge of the Marquette campus. The concept of the Athletic Performance Research Center is we don't know as much about athletics and performance as we should, and that translates very well to the whole population. So what we're working on together is from childhood to professional athletes, looking at what happens to athletes along the way, how they train, how they rehab, the behavioral health aspects of athletics, which are enormous and unstudied. We're going to research those together, and we think that this will be good for everybody involved. It's good for Marquette for the reasons you might think about. It's good for their athletic programs, their research programs, recruitment of faculty, recruitment of students. It makes sense. It's good for Aurora because we're heavily involved in research. We actually do more research at Aurora than any other institution in the state of Wisconsin. Little known fact, but we do a lot of groundbreaking research, including the gentleman right here. So, research is great for us. What we learn about patients is great for us. We're involved with athletic teams all across the state of Wisconsin. We will apply that knowledge quickly. It's good for our programs that have coexisted with Marquette around physical therapy and occupational therapy, help develop those. Behind the scenes for both Marquette and Aurora, we also have a commitment, Mike Lovell and I do, to make Marquette the healthiest campus in the country. Now that is a big deal. This gives us a little bit of a nidus to work together, but we are very committed to making this a very healthy and special campus. This is good for Milwaukee for the reasons you might imagine. Brings jobs. It connects parts of the city, in my mind, that haven't really been connected. Connects downtown to near West Side, begins to be a bridge to the 3rd Ward and Walker's Point. This is good for the redevelopment of our city. What the Bucks are doing, and they're, by the way, involved in this project as well, the arena, huge redevelopment. So we have an opportunity to change the face of Milwaukee. We're taking that opportunity. And this is just good for Wisconsin. We do great things here. We're pretty humble about it in Wisconsin. We don't talk about how great it is here, and we have to do a better job with that. So if you look at this now from Aurora's perspective, I've had the privilege of being in this job for almost 10 years. And when I started in this job, we were very worried about balance sheet improvement, getting cost out, integrating the system. And we've done those things and done them pretty effectively. Now we have an opportunity to give back to the community. And we're doing that in a couple of ways. We have a Better Together fund where we're funding things like sexual assault and domestic violence, behavioral health, primary care access across the city. That's our opportunity to change what happens here, just like what we're doing with Marquette. But I also think it's the responsibility of private businesses to say, if we are going to make this a great place for our children and grandchildren, if we're going to keep millennials here, if we're going to create a Milwaukee that everybody's proud of for the next generation, then every company has a responsibility to do what they can do. And we all do it at different levels and in different ways and different ups and downs with our company. But I do think we have a responsibility to do that. And I'm just pleased that we're in a position to be able to make a difference in a new way in Milwaukee. So I'll stop there, and you can ask me about anything. I think after 10 years I've heard almost every question, but maybe you can surprise me. Thank you. Yes?
With all of these partnerships
think we're pretty fortunate at Aurora that we started measuring quality about 18 years ago. When the science was early, it's better developed now. But we don't do anything without goals, timelines, and measurement. So Dave said that I brought more of a doctor's approach. I think that's true, but just like in medicine, it's a combination of measuring results and looking at data and having a relationship with a patient or an institution that you can make good on. So all of the things that I talked about with examples have timelines, goals, and I'm fortunate to have a great team that works on the implementation and makes that real. Because without that, most of the partnerships will fail. I think they fail because people don't always have uniform expectations of what you're going to get to on the other side. So we try very hard to have measurable goals for all that we do. Yes?
Some of the other major projects that have been going on in town, the Northwestern Mutual Tower, the Bucks Arena, have diversity hiring goals and diversity training programs involved. Will there be such programs in this project?
So let me talk about this from the Aurora standpoint, and if Dave, if you or others from Marquette want to answer it, we can certainly share the microphone. At Aurora, we take care of virtually every population across eastern Wisconsin and northern Illinois. So we take care of diverse populations, and I mean diverse in every sense of the word diversity. We think that who we hire and develop and bring into the organization needs to reflect the community. So we have a very strong commitment to diversity and inclusion, because if we don't have an inclusive environment and a good listening environment, we know it's not going to work. So the answer is, in everything that we do, we are looking at diversity and inclusion as part of how we hire, whether it's faculty researchers that go into this project, whether it is the way we work with vendors. Yes, the answer is yes from our standpoint. And as we work collaboratively with Marquette, I think I can answer safely for Mike Lovell that he is extraordinarily committed to that as well. Safe to say? Yeah. Yes?
In the last several months, it's my understanding that Aurora has stated an interest in focusing on pediatrics. And in the light of partnerships and the fact that there are 2 outstanding children's hospitals in the state, I'm wondering if you're partnering with either or both.
Sure. We are, yes. So the easy answer is yes. We have within Aurora about 100 pediatric providers, and then a lot of family physicians who also do pediatrics. So if we look at what we provide, about 18% of what we provide is pediatric care. We have 2 really excellent inpatient facilities in this state. One here, one in Madison. Both of them with some extraordinary strengths. And we don't have any interest in trying to compete on that front. What we do have an interest in pediatrics, just like adult care, is getting doctors to where the patients are. So our model, if you look at our rural communities, we've infused a lot of specialty care into rural communities because we think we should go to the patients. Doing the same thing in pediatrics. So we have an active partnership going on now in Green Bay with UW Children's Hospital, where we have primary care pediatricians, nurse practitioners, and family doctors who have a pediatric clinic in Green Bay. UW sends specialty physicians to that site. So it's about bringing care to the patients. We've worked with Children's for years on a number of projects and have a list of things that we're working on with them right now, and a couple of possibilities that are a little early to report on. But the answer is we want to partner. But let me also say this. If you look at our About Health partnership, the statewide partnership, there are people in there I mentioned that we still compete with. We compete pretty intensely. I'm a competitive person, and I think that raises the bar on quality for healthcare. So there will be areas that we overlap or compete or have programs that are somehow parallel, but that doesn't mean we can't collaborate too. And I think the trick is finding that magic zone in the middle where you learn how to do both. We went through a period of time in Milwaukee where nobody could do that. Nobody could make sense of the either or. It had to be one or the other, but nothing in the middle. I think we're emerging from that. And if people, people will speculate about that, and that's all right. We will do the right thing for the patients we take care of. Yes?
What are your objectives for the new center?
So, Mike Lappin, if I missed something here, Mike is the lead for Aurora Health Care on the Marquette project. We have, how many work teams? 9 work teams going through all the aspects of goals, timelines for this center. So a couple of key things. One of them is around what research is being done in the center. I mentioned a few of the things, but we have about 6 different categories of research where we're looking at talent within Marquette, talent within Aurora, or talent that we want to recruit in the research area. So some of the biomechanics of training, how you train people and keep them fit, that's one area. How we rehab people and use physical therapy effectively. We do a lot of physical therapy. We want proof of concept in all that we do. New devices that are now, there are tons of devices flooding the market that are supposed to make you healthier, mostly untested. So some of what we'll look at for athletes is what can you use for technology that can make people better or stronger or healthier. And I mentioned behavioral health because we have a huge commitment at Aurora to behavioral health. It gets a little bit of press, but it's the unspoken tragedy in American healthcare that until we take away the stigma and fix what's going on in behavioral health from access and payment perspective, we are going to continue to fight physical problems that have a behavioral health basis. Absolutely true in athletes as well, who endure a lot of different kind of pressures. And particularly in the college and professional athletic world, it's been one of those kind of secrets. Nobody wants to talk about having a behavioral health problem. We want to shine a light on that, so you can expect that will be a major area. That's the research area. Then in the clinical area, we do a lot of work with Marquette and with other teams on training, physical therapy things, so we'll have a clinical presence in that building as well. And then there's a lot of work being done on the healthiest campus idea, because going from where we are today to getting to that status, we have some work to do. There's been inadequate attention, particularly at the college level, of what happens to students as they transition from high school into college. It's a pretty risky time in many ways. So we think there's a lot we can do in that area. Mike, did I miss much? Oh, good. I'm trainable, right? Good. Yes?
Nick, I was wondering if you have any thoughts on the proposed monumental changes to the family care program and the effort to integrate long-term care and acute care.
Sure. So the question is about efforts to integrate and change long-term care and how we approach family care. I never answer questions that I don't have the depth of knowledge to answer, and I would say this is one of those areas that I can't answer specifically because I don't know enough about the details, but let me answer generally. The more we can integrate the different aspects of care, the better off we are. What happens to people when they leave a hospital and go into long-term care or go back and forth is an area that we're studying and working on at Aurora, because it happens so frequently and it's been largely disconnected. So I'm very much in favor of efforts that integrate what we're doing, but I probably don't have enough specifics to go beyond that. Yes, thanks for the question. So definition of behavioral health, which I should have talked about earlier, for the way that we use that term encompasses all the things we do in mental health and all the things we do in the substance abuse and addiction area, because there's so much crossover. What we're doing in smoking cessation, we're trying to integrate into all that we do clinically. Primary care, hospital. It would be hard to come to Aurora without somebody talking to you about that. And we know that persistence is how we get there. But that's those things. Behavioral health is really that set of mental health, and addiction and other substance abuse disorders. We have at Aurora Psychiatric Hospital, which was the old Milwaukee Psych, about 150 years old. We have inpatient units at a number of sites around Aurora, but more importantly, we're infusing mental health workers into primary care and emergency departments because we want to begin to address needs real time. The problem typically right now is primary care doctor sees a patient, makes an appointment for 2 or 3 weeks down the line, if you can get one that soon, and the patient by that time perhaps has had a crisis or doesn't go in for the appointment. We want to do real-time work on behavioral health to try to say, if you're in the clinic and you have a problem, we want to get you help right now. Yes?
I spent the winter down in southwestern Florida, and I think the federal government's coming out in early July with ratings of hospitals. Well, down there, it kind of leaked out, and we were surprised how low the rating was. Do you know what Aurora's rating is going to be?
Sure. So the question is about ratings for hospital. Is that the CMS, the Center for Medicare and Medicaid? So here's the difficulty. We just spent a little time with our board of directors on this issue. There are probably over 100 different agencies that rate different aspects of healthcare. There are probably a dozen that are commonly looked at. And when you line those up, they don't agree. So you can have a 4-star rating in one and a 1-star rating in the other because it depends on how things are evaluated. What we're advocating for right now at the federal level in particular is we'd like to know what's a bit of a black box right now. We want to understand how they're doing the ratings. So they've delayed publishing those at least till July, but it may be longer. And I think what we hope that CMS is beginning to understand is that we want things to be really good too. We want high quality. We measure and report all those things. But we think the only fair way to do public ratings is to understand what's in the formula. And right now, it's a little bit clunky. They haven't always done a very good job with things like severity adjustment. So you might have a center that does very complex surgical procedure. I'll give you an example. Heart surgery. To do a heart surgery the first time is a pretty simple procedure that's done in a lot of places. To do a heart surgery on someone who's had one 2 or 3 times and now is having redo, the complication rates by nature go up. If you don't factor that in, then the hospital over here doing the harder cases, maybe with the best surgeons in the world, may come out different on the ratings. So what we think from the previews is that we're going to do well on those ratings, and Wisconsin hospitals in general, I'm really proud of. We have generally by federal standards, Wisconsin and Minnesota end up flipping back and forth between number 1 and 2 on quality. So we tend in Wisconsin to be higher. And I'm talking about not just Aurora, but everybody. This is a really good, committed state for healthcare around quality. I don't think the ratings are exactly ready for prime time. So we've been writing letters, working through Hospital Association and others to say, just open up the black box and tell us what you're measuring. Is that helpful? Good. Yes, sure. So the questions around social determinants of health, what Aurora is doing. I actually have the book, The Healthiest City, in my bookshelf because our aspiration is we're going to get back there. There are, at one time, Milwaukee was considered the healthiest city. It had a very robust public health department. And if you look nationally now at what's happened, there is not much funding for public health. You look at the Milwaukee Health Department, where I think Bevan Baker does a fabulous job, has very limited resources and staff. So the burden, if you will, of public health begins to fall to social service agencies and healthcare providers. What we have tried to do, both at Aurora and for example, in our Milwaukee Healthcare Partnership, which is all the healthcare organizations in the city, is to ask where we can make a difference and try to invest those funds in things that we think is will really matter for the population. So in some cases, it is around things like access to healthcare providers, where, it's fine to have coverage, healthcare coverage, but if you don't have good access, if nobody is in your neighborhood, it's pretty hard to get healthcare. So at our Sinai campus, we have a new urgent care center with one of the federally qualified health centers. Better access, easier for people. They don't need to go to the emergency room. They need health care, primary care. So we're doing things like that around access. We're doing things around vaccinations, both within Aurora and then working with the health department. We're working on things with the schools around trying to prevent obesity and so on. If you look at all the social determinants of health, there are some we know we can't solve. We can't solve some of the housing issues, although we work with people to try to help that. So we try to look to where we can have an impact related to healthcare. That's why I mentioned our Better Together Fund, where we're investing in community-based organizations. A lot of these are small organizations that don't have the bandwidth they need. And if we can improve access around behavioral health, sexual assault and domestic violence, that's one way of addressing some of the social determinants. So it's a little bit of a rambling answer, but I would say if you look at healthcare in this country and you look at the cost of it, if you strip away what we spend on public health related issues, our healthcare costs come into line with other countries that have a more robust public health program. So there's actually good literature now showing that a lot of the healthcare cost that gets shifted to businesses is because we don't have a good public health infrastructure. And that we're not going to solve quickly. Yes, sure. So the question's about what are the success measures? I think I touched on a number of them in the earlier answer. It is demonstrable progress in research, demonstrable progress in recruiting people in research at both Aurora and Marquette, partnering with other organizations like the Bucks to have an impact on athletes, like hopefully Children's to have an impact on childhood athletes. So those are the initial success criteria. I'll tell you, in the last 3 months, that's been where we've spent most of our time, because what we want is alignment between Marquette and Aurora on how we're going to measure success. And an academic institution and a healthcare provider, it's two different cultures. So Mike has spent a lot of his time, along with Rachel and others, saying, how do we get to that sweet spot? So we're getting there, but some of that's still in development. Okay, thank you all very much.
An MCM production.